Hello, good afternoon. First of all, I would like to thank GSK and the coordinators for inviting me to this meeting in this wonderful city. And I would like to thank you all for coming and for your interest in this talk. I'm going to talk about the new horizon for people with HIV, long-acting regimens. Here you have my disclosures. Before starting talking about the data about cabotegravir and rilpivirine, long-acting, I have to make 4 questions. The first one is why? Why do we need new strategies to treat our patients if we have excellent options? The reason is the stigma for some patients having treatment at home, for example, adherence anxiety, for those patients who daily medication create an anxiety, or the daily reminder of HIV taking every day the pills. Here you have many options for treating patients, many options that you have here, the guidelines, the recommendations, the national, the European, the American, and the international options, and all of them are excellent options. So nowadays, we are moving on to two regimens, 2 drug regimens. This means 2 drugs instead of 3 drugs, and with oral presentations like dolutegravir lamivudine for naive patients and also for experienced patients, and in solutions, in injectable solutions like cabotegravir rilpivirine. However, we need this option, the long-acting, to solve some of the issues that I mentioned before, like a stigma or like the daily remind of HIV infection. The second question is what long-acting regimens are available. Nowadays, cabotegravir and rilpivirine long-acting are available, and cabotegravir is a new integrase inhibitor similar to dolutegravir, and rilpivirine is a non-nucleoside inhibitor. Both are available as pills and also as solution long-acting suspensions. How does it work? You can start with oral lead-in, with an oral phase, 1 month of treatment, oral treatment, or you can start directly using the injections. A baseline injection, the second one is at 1 month, and every 2 months thereafter. Here you have how does the combination work. Cabotegravir and rilpivirine are administered as separate gluteal injections. Then the suspension form a drug depot in the muscle, and the drug is slowly absorbed from the depot side into the bloodstream. The last question is when can we use this combination? Cabotegravir rilpivirine is for those patients biologically suppressed on receiving antiretroviral treatment, those who without resistance to non-nucleosides and to integrase inhibitors, and without chronic hepatitis B. And of course, for those patients motivated and with able to attend the injections visits. Let's move on the data about cabotegravir rilpivirine. Here you have the clinical development program, a very wide program, but I'm going to focus only on these three studies. FLAIR study and ATLAS study are studies, phase 3 clinical studies, in which we compare oral treatment with monthly injections. The first study, the FLAIR, is in naive patients, and the second one, the ATLAS study, is in virologically suppressed patients. And the third study, the ATLAS-2M, is a study, a switch study, and in which we compare monthly dosing of cabotegravir rilpivirine versus every 2 month injections. Talking about efficacy, the 3 studies show a high virologic success around 95% at 1 year follow-up. We have similar data after 3 years follow-up from the Atlas 2M study, around 80%. And we have even a follow-up of 5 years in the LATE 2 study, around 84%. So a high efficacy with this combination at long term. Let me spend some minutes talking about 2 studies. The SOLAR study is the first one I want to talk, is the switch study, in which I think that it's important, an important study, because it's a switch study, a head-to-head study, where we compare cabotegravir rilpivirine versus Biktarvy. Here you can see that patients with Biktarvy were randomized, around 600 patients were randomized to continue with Biktarvy or to switch to cabotegravir rilpivirine using the oral phase or without the oral phase. The efficacy was really high, around 93%, and with a very low biological failure. Here you have that only 3 patients, this means 0.4%, presented a biological failure with mutations. So high efficacy and a very low rate of virological failure. The second study that I want to talk about is the CARES study. This study was conducted, is a switch study too, and was conducted in Africa. 500 people were randomized to continue the oral treatment or to switch to the cabotegravir rilpivirine every 2 months. You can see that the retention was almost all patients arrived to achieve the week 48. In this study, as I said, they were randomized to continue with the oral or to change to the cabotegravir rilpivirine. And when investigators assessed the PBMCs from stored samples at baseline, they realized that half of the patients presented HIV subtype A1, and 15% of patients presented mutations at baseline to rilpivirine or cabotegravir. These factors are predictive factors of virological failure. However, even in these conditions, the efficacy was really, really high. Remember that almost all patients arrive at a year follow-up, and all of them, most of them, arrive with a viral suppression. Only 2 patients from out of 500 people presented a virological failure, one a confirmed virological failure with resistance, and the other one without a confirmation because he died before the confirmation. So a very low rate again of virological failure. Considering the data of the FLAIR, ATLAS, and Atlas 2M studies, you can see the low rate of failure, 1.4%. Only 1.5% of patients presented in these studies a virological failure. Multi-regressional analysis show that a baseline resistance to rilpivirine, HIV subtype A6 or A1, and a BMA, a body mass index of 30, or over, it means obesity, are predictive factors of virological failure. If you don't have any of these factors, the risk of failure is 0.4%, a very low rate. If you have one of them, the risk is 2%, and if you have two or more, it's up to 20%. You can avoid the risk of body mass index using a longer needle length. Using this needle, the pharmacokinetic levels are similar to the patients with a lower body mass index, and the efficacy is similar between both groups. A key message and a take-home message is could be this one. For as you can see in this figure, the risk of virological failure is mostly during the first year. After that, few patients presented in these studies a virological failure. This is important. What about safety? Headache, fever are some of the adverse events, but the most common adverse event is the injection site reactions, mainly pain in the local, in the injection site. Pain is very common, but usually most of them is mild, and the duration is 2 or 3 days only, and less than 2% discontinue or stopped therapy because of the adverse event. Another key message or take-home message is that this pain, local pain, occurs mainly during the first 2 or 3 injections, but after that, the local pain reduce or even disappear in most of the patients. So it's very well tolerated. What about drug-drug interactions? We have cabotegravir rilpivirine bypass the gut. Then there is no food requirements, no pH constraints. For example, omeprazole that we can't use with other oral regimens, and there is no binding to polyvalent cations like supplements with iron, calcium, magnesium, that we can't use with other some oral treatments. However, the drug-drug interactions at the hepatic level can still occur, and then we should avoid the combination of cabotegravir rilpivirine with anticonvulsants, with antimycobacterials, and with glucocorticoids or herbal products. If you ask the patients about the preference after 1 year of treatment with cabotegravir rilpivirine, most of them said that they prefer to continue with this regimen instead to come back to the oral treatment. And this is very important because this is the opinion, the patient opinion, the patient's voice. What about the real world? What happened with the real world cohorts? We have data of almost 9,000 people. And this means that we have data, including also the clinical trials, of more than 11,000 people using cabotegravir rilpivirine. And in the real world, the efficacy is similar to the phase 3 clinical trial. So very high rate of virological efficacy. With a very low rate, the second line, a very low rate of virological failure. And with similar rates of discontinuations around 2%, 2.5% of patients discontinued stop treatment because of adverse events. So really nice results from the real world cohorts. Let me finish with the last part of my talk, talking about our experience with cabotegravir rilpivirine in our cohort. We are attending in our unit 3,000 people with HIV. Almost 200 nowadays are receiving cabotegravir rilpivirine, long-acting. Most of them are young people, young men, with a mean age of 30 years old. They are on her first or second line of treatment, and most of them came from Biktarvy. Is the most common switch from Biktarvy to cabotegravir rilpivirine. We started using cabotegravir rilpivirine 1 year ago, so we have the experience of 1 year with the commercial cabotegravir rilpivirine, but we started using this combination 5 years ago or more, using with patients who participated in the Atlas 2M study. Although our experience is mostly in young men, we are started using this combination in other profiles. For example, we are using cabotegravir rilpivirine in those patients who prefer less frequent dosing because of the stigma, having treatment at home, or because complex schedules, travels, or because they have difficulties with oral treatment because of gastrointestinal disturbances, or anxiety to continue oral daily medication. Also in women that many times are caregiver and don't have time to take care of themselves, or women usually have more stigma than the men, or immigrants, or people with unstable living conditions without home, or teenagers, for example, that they prefer less frequent dosing. Or why not in old people, because they are receiving a lot of drugs, and we can avoid a number of drugs, and we can reduce the potential drug-drug interactions. So to summarize, in conclusion, I think, in my opinion, that cabotegravir rilpivirine long-acting every 2 months is a very good option for many people, because not only the high efficacy of this regimen, the low rate of virological failure, and the low rate of drug-drug interactions, and the good tolerance, but also because many patients can take benefit of this combination and reduce the stigma and other issues that I mentioned before, and improve their quality of life. Thank you very much.